Hey, welcome everyone to the infectious diseases part 2. Now we talk about HIV. So HIV, what are the pathophysiology or the first test that we do, or let's do the pathophysiology is gonna affect the chest CXCR4 and CCR5 receptors, and it's gonna affect the GP120. Okay, and then it's an RNA virus gonna goes inside. It's an RNA virus, uses the reverse transcriptase. So that's what it uses. How does the patient present? The symptoms wise is gonna present also either opportunistic infection or acute retroviral syndrome. Like after this process happen, it can cause opportunistic infections, so it weakens the immune system and open the door for other bacteria to go and other microbes, or it can cause acute retroviral syndrome. Okay, so that's the thing about the HIV. How do you diagnose it? You diagnose it, you can order the antibody test, which is by ELISA, and then if it's positive, then you do Western blot. Okay, it's called the you can do third generation antibody. If that positive, then you go to Western blot if positive, or you can do the fourth generation antibody confirmation built-in confirmation, and you can, after that, you order the viral load, and you can order the CD4 count. This is important too, CD4 count. How do you treat it though? That's an important thing. How do you treat it? You treat it 2+1, 2 nucleoside reverse transcriptase inhibitor and 1 from either protease inhibitor, fusion inhibitor, or non-nucleoside reverse transcriptase inhibitor, or integrase inhibitor. So usually 2 nucleoside reverse transcriptase inhibitor plus 1 from either non-nucleoside reverse transcriptase inhibitor or protease inhibitor or fusion inhibitor or integrase inhibitor. Okay, usually the most common 2 NRTI and 1 integrase inhibitor. They have the least side effects. So after that, how do we follow up with that? After you treat it, you follow up with CD4 count. Okay, and the viral load, you should fall 1 log in 4 weeks. Viral load. The CD4 count should increase by 50 every year, and the viral load should fall 1 log every 4 weeks. So this is the treatment modalities. When do we give prophylaxis? Prophylaxis to HIV. Okay, so prophylaxis to exposure. What do you treat? Like prophylaxis to exposure, like when you think that you might have an HIV, what do you do? So you can do the pre-prophylaxis. You can give imitricitabine plus tenofovir, and then you can, there's in the post-exposure prophylaxis, you give imitricitabine plus tenofovir plus minus raltegravir. So this is for the post-exposure prophylaxis. This is pre-exposure, before you expose. This is to prevent. This is the post-exposure prophylaxis. If a pregnant woman need a HIV prophylaxis, you can do AZT. Zidovudine. So when do you give so there's another prophylaxis for this is prophylaxis for HIV. There is another prophylaxis for opportunistic infections. So let's talk about the opportunistic infections, because that's how HIV could manifest. So PCP, when do you do prophylaxis for it? You do when the CD4 count less than 200, and first you start with TMP SMX. Second line you can do dapsone, or you can use atovaquone. Okay, if someone who's allergic to sulfa, or G6PD. So this is the opportunistic infection for PCP. How about what are the treatment for toxoplasmosis? Toxoplasmosis usually when the CD4 count less than 100, you give azithromycin. Okay. How about Mycobacterium avium intracellulari, MAC? When do you prophylaxis? When the CD4 count goes below 50, sorry. And then you give azithromycin. Sorry, for toxo is trimethoprim sulfamide, so TMP SMX. But for MAC is azithromycin. That's the management. How about HHV8? What is that? This causes Kaposi sarcoma, which present as a purple lesion anywhere in the skin. Purple lesion in the skin. This is the HHV. How about Candida? Candida could infect the oropharynx. And how do we treat that? You can give nystatin, swish, and spit. No need for systemic therapy, local therapy. Or it could infect the esophagus, which is more serious, so we use a fluconazole. So systemic therapy, oral, PR. For the people, therapy for AIDS defining illness. So this is one of the AIDS defining illness, Candida esophagitis. So these are the opportunistic infections. So in a nutshell, summary for HIV, usually it goes into the CCR5, CXCR4, and suppresses the immune system. You diagnose either antibody test and then Western blot, or there's an advanced 4th generation antibody could confirm that. Viral load, CD4. How do you treat it? 2 NRTI plus 1, either NNRTI or P protease inhibitor, fusion inhibitor, or integrase inhibitor. Okay. The prophylaxis for HIV: before the exposure, imitricitabine plus tenofovir. After the exposure, imitricitabine, tenofovir, and dolutegravir. If pregnant, you do zidovudine, AZT. Opportunistic infection: if a PCP, usually CD4 less than 200, you give TMP SMX or dapsone. Or if allergic, and then you do atovaquone. If the toxo, you worry about it when CD4 less than 200, so you give TMP SMX. MAC, Mycobacterium avium intracellulari, you worry about it when CD4 less than 50, you give azithromycin. And Candida, in the oropharynx, you give nystatin. In the esophagus, you give fluconazole. And the last, HHV8, could cause Kaposi sarcoma, which is a purple lesion in the skin. There's no prophylaxis for it. And that's a summary of AIDS. Thank you so much for listening.